Welcome to the Cincinnati Children's Hospital Heritage Video Series sponsored by the medical and dental staff of Cincinnati Children's. I'm Dr. Manny Doyne, a member of that committee. The topic today is the lead clinic at Cincinnati Children's and many other topics. Our speakers today are Dr. Omer Berger, who's Emeritus Professor of Pediatrics and former Director of the Pediatric Environmental Health and Lead Clinic and Pediatric Medical School Clerkship. Our other interviewee is Dr. Nicholas Newman, who's Assistant Professor, University of Cincinnati Department of Environmental Health and current Director of the Pediatric Environmental Health and Lead Clinic. I wonder if each of you could give me a brief biographical sketch up until the time you became faculty at Cincinnati Children's. Dr. Berger, would you start, please?
Yes. Well, I started out in a family medicine training program, and within about 6 months, it seemed unsatisfactory. The Vietnam War was heating up. Doctors were being drafted. The resident that I was going to go into practice with was drafted into the Navy. I decided that probably I would be drafted and that I didn't really have to worry about what I was going to do next year. And so it turned out I was 4F. I was not going to be drafted. I had an eye problem. And so I happened to be on pediatrics at Miami Valley at the time. And then I realized what I really wanted to do. So we began applications in March. This was before the matching program affected residents. It would just apply to interns at that time. And so I decided not to apply here because I knew it was probably filled for about 12 months already. But as it turned out, someone was drafted out of the program. And so there was a spot. And within a week, I was accepted. And so we knew what we were going to do. And so came down and was a resident for 2 years. And then at that point, I was invited to do a fellowship in the outpatient department with Dr. Hugo Smith. And so I decided to do that. And that was a very interesting year, all in the outpatient. And I also had a lot of free time. I had teaching duties with med students and with the residents. I could attend, when I had some time, I could attend various clinics that I was interested in. And it was really wonderful. There was no night call. And we had 2 small children, and so it was really delightful to spend more time at home. And also there was a possibility of doing research. The National Pituitary Agency was formed, and it was proposed that pituitary or growth hormone deficient children would receive human growth hormone. It was actually derived from bovine sources. And so there was a national meeting about that. I got to go to that. We recruited and treated, can't recall the exact number, somewhere between 5 and 10 young people in that year. And so it was very stimulating. And so after the year was over, I went into private practice with 4 other pediatricians. And I found that quite challenging, especially the idea of night call. I was the new person in the group, and so oftentimes they would say, gee, could I sign out to you tonight? And so very often, I wasn't busy during the day, but I would get home and start mowing the lawn and getting grease on my hands, and then there would be a call to come, a laceration to suture, et cetera, et cetera. And it was really, that was interesting, but a little frustrating. And I had the sense that I wasn't really very good at it. Of course I wasn't, I just started. But nevertheless, when the call came from Children's, from Dr. Bob Lyon, talked about plans to expand the OPD faculty. And you have to remember that in those days, the biggest OPD was here at the at the Cincinnati General Hospital, and so and the ED. So it probably saw many more outpatients there than here, and so I really liked all the people that were on the faculty here, and so I thought this would just be perfect, and so that's what happened in October of '68, and. Shall I go on from there?
We'll probably, the next step is going to be more interesting and complicated, and
Right.
we'll talk about that in a bit.
Okay.
Dr. Newman, tell us a little bit about your life before you came to Cincinnati.
Sure. So I've trained as an osteopath, a DO, in Kirksville, Missouri, and the way the school was structured then was there really weren't enough clinical rotations for us in rural Missouri, so they farmed us out, and so I was sent to Detroit, Michigan for the last 2 years of medical school, and then I stayed on in Detroit as a rotating intern through the basically in the Henry Ford hospital system, and then I was kind of trying to debate between family medicine and pediatrics, because my wife's a family doctor, and I decided on pediatrics, and I stayed at in Detroit at Children's Hospital Michigan, Wayne State, and completed my training there, and then went into private practice. And I worked. I was in a good group in West Michigan. And I have to, Dr. Berger's, like, there was certainly a lot of being called into the hospital, but it was a good group of people, and but I did that for about 7 years. But during the time, I would go to like the yearly AAP conference in Michigan, and I got one year. I remember we were on Mackinac Island, and there was a talk being given by. Bill Weil from Michigan State, who now has passed away, unfortunately, but he really was one of the early people who identified that environmental health was something really important for children. And he'd been an endocrinologist by training, but had seen like a whole bunch of things in his career. So he just had a talk. And after the talk, I went up to talk to him at the podium, and he and I and a couple other people went to the hotel lobby and decided we were going to form a committee on environmental health for the Michigan AAP, and at that moment, so we had some support from our local colleagues, and we started doing kind of we had a show on the road or whatever. We would go and talk at local hospitals in Michigan, and what I found was that people were starting to ask me questions that, like, I was an expert. And I didn't feel entirely comfortable with that. And felt that if you're going to put yourself forward as an expert, you need to have something to show for, that you really are. So I came to Cincinnati to be with the environmental health group that was down here, and ultimately completed fellowship in occupational environmental medicine, and also did a master's degree in a kind of related field.
So, Dr. Berger, we've talked about this before. So you were working in the outpatient clinic at General Hospital, which is now University Hospital, and you were working with, I think you said, Carl Weil?
Correct.
So how did that evolve into you being the director of the lead clinic?
It was very complicated. Besides working in the clinics at the General, and one of the reasons that I was hired, and at the same time, Marilyn Gaston and Bob Engberg. I can't remember exactly who came first, but at any rate, they also came, people that I knew from residency, et cetera. And but it also involved going out into the community. So the Baby's Milk Fund was the outreach arm of the CGH Pediatrics, really, in a way. And then another thing that Dr. Lyon, who is behind the scenes, doing a lot of these things, seeing where the needs are, decided that the area in Addiston, Sailor Park, areas far to the west of the city along the river were markedly underserved. And so we started the Addiston Clinic in a very small area in the manse of the, I forgot which church it was, but at any rate, it was a very old building, a very interesting experience. And so we would see large numbers of patients, you can probably imagine, and you've had that experience too, way more than you can comfortably see at times. And so that would be, so I went every Friday morning out to Addiston. And from our house in Montgomery, that was quite a long trek. And then we'd come then back to the medical center. And so, so between the evening, I guess I didn't mention it. So we established an evening medical clinic. The big problem was the emergency department at CGH had too many pediatric patients, and many of them really didn't need to be in the emergency department. So they would shuttle them over to us. The emergency was in B basement. Our clinic was in C basement. So they could just go right around the corner. And then we had a receptionist. We had a great nurse. And so one of us was there every night. A couple of newborn fellows were moonlighting. And wait a minute, I think I took 2 nights, and I think Bob Engberg had 2 nights, so we only needed 1 moonlighter in the beginning. And we also had a freshman medical student that we were, it was a brand new program. And so, I mean, this was really good, but in some ways it took a lot of time. But now let's see, how can we get from here to the lead clinic? So that's what was going on. And
well, the first director was who?
The director of the lead clinic,
Bob
yes.
Reese?
It was Bob Reese, yes, exactly. Dr. Smith, my fellowship director, became a dean at Temple, opening up that job. And Bob Reese, who was at Boston Children's and was working with John Grafe and Frank Lovejoy and others with the problem of lead poisoning, came to Cincinnati. And probably just about the first thing he did was to organize a mass screening in Mount Auburn, a door-to-door type thing to get everybody. And what it showed was that there was a massive amount of increased lead absorption and frank lead poisoning in Mount Auburn. And so Bob set up a lead clinic, and this was all going wonderfully. And so 2 years later, it was in the beginning of '72 at least, he said that he was going back to Boston.
Right.
And he had other staff that he had also brought from Boston who were running the lead clinic, and so they all went back to Boston. And I'm not sure why I said yes, but it was, you know, I thought it was a very interesting problem. So, so I rapidly learned about lead, and by August I was giving grand rounds on lead poisoning. This was there were 2 grand rounds in those days. There were grand rounds at the CGH and in the Monterey classroom. And so, so I found my notes on that, and I was surprised how comprehensive they were. Like, did somebody do this for me? I'm not sure. But at any rate, that's how I got into it.
So at that point in time, you were not just working in the lead clinic, though.
Oh, no.
Tell me your other duties.
Oh, yeah. I was over at the convalescent hospital. I was Bob Engberg and I were Joe Gorey's understudies. And so either Bob or I made rounds at convalescent daily. And I mean, that was interesting. That was really interesting and very pleasant, wonderful people to work with. So I learned a lot about rehab, and they had that's where all the physical therapists were.
Mm-hmm.
So I learned OT, PT, you know, we had group conferences. It was just really terrific. I'm not sure how all that got squeezed in. But the convalescent then closed with the building of the big new, I forgot what it was called then, the pavilion building. And the convalescent moved to the pavilion, so I didn't need to do that anymore. But at the same time, Don Frank said he would love for me to come to Good Sam. So I became the residency director of Good Sam. I can't believe this. And we had a wonderful clinic. I didn't do any of the newborn over there, except on Sunday mornings when Don would sign out to me and ask me to see the newborns. And so, so the whole family went to Good Sam Hospital for breakfast, and then actually I saw the newborns first, and then we went down. To breakfast. So, and that was really fun. And
you were still working in the outpatient department at General?
Yeah, in the Baby's Milk Fund and
Baby's Milk Fund.
all that stuff.
So how many days a week was the lead clinic? Was it 1 day a week?
Just one day a week,
Okay.
right? Yeah.
And
Yeah.
what was the state of the art in terms of the kind of patients you were seeing, the technology you had, the treatment, kind of conditions they presented with?
Right. Yes, basically we had very swiftly gone from the only lead poisoning we recognized was symptomatic, lead encephalopathy, if you will. Getting a lead level was practically required an act of Congress. And so they were done down at Kettering Lab, and they provided a kit, explaining all about lead poisoning and what kind of specimen to send. But they basically wanted, I can't remember, it was 2 or 3 vacuotainers, but it was an awful lot of blood to draw. So you didn't really order a blood lead unless you had a pretty good idea that it was necessary. It definitely couldn't, it wasn't a screening tool in those days. But so the Surgeon General made a statement, or was it? Yeah, it was in 1970, followed by a congressional act, a lead poisoning act that made funds available so that local health departments could afford to buy the lead testing equipment. So the stuff they were using in Boston, ESA, they were doing protoporphyrins and leads, and we weren't doing any of that here. So that made screening possible. So more kids were being turned up, not nearly as many as later. The more we looked, so screening started out slowly. So the volume in the lead clinic wasn't terrible.
Well, the health department was doing the screening. Is that what you said?
Yes.
Yes.
And the health department was excellent. They had great people. Jackie would come. She'd bring all the data from the health department, and then we'd go over it. And then I'd decide, we want to see this one right away. We'll see this one in a couple of weeks, et cetera. Let's get another lead on this one, and we decide what to do with them. And the lead clinic nurses at Children's were just unbelievably excellent as well. They were interested in lead too, and they really did a lot of the kinds of things that doctors would normally decide, make the decision on in those days. And so all along, and that went on, and the relationship between the health department got better. I got to know the people in the lab, and the health department sanitarian, and Judy Daniels, who was the
commissioner.
Commissioner of Health?
Yeah.
I think she was, wasn't she? Yeah, I'd known her before she did that too. So, there was a certain ease, and it was a pleasure. And so how do we treat them? Yeah, we were still using EDTA, IM or IV. I think it was actually, no, it was IV, and it was BAL was the IM, and so they had to be admitted.
And what level of lead did that require to get chelation? What was the magic number?
I was trying to decide that, looking over my old notes. I know it was certainly anybody with symptoms or lead above 70. I think that was the threshold. And that changed many, many times. It's still may be in flux, so you need to find out from Nick.
I think it's less than 1 now is the norm.
Lead was?
Well, it's less than 1.
Yeah, okay, it probably is. Yeah, you would want your child to have a light of less than 1, absolutely. And so they got admitted, and then I would follow them along with the residents, and they were almost all at the general. And so.
And the health department was doing abatements of houses at that point?
I don't think, I'm not sure, I don't think they were at that point.
Yeah.
But, you know, they were finding hazards, and you know, I don't remember much exactly what the state of the art was there.
Okay.
So,
And you were director of the lead clinic for how long?
until 2007.
So that's 30. You don't want to
I don't
say
really
that
know.
number. Okay. So
Anyway.
there was a point in time when you became a director of the pediatric clerkship at University of Cincinnati.
Right. Yeah. Yes,
And
it's
I
true.
think that 30-year thing held true for that.
No.
Not that
was,
long.
yeah, Carl Weil was the director from the time Al Maurer left for Iowa, or no, where'd he go? Memphis. So Carl Weil did it really well, and so I was working with Carl a lot, and I would also sub for him at times, you know, because he had some problems with, and then he couldn't. He got to the point where he couldn't work in the morning anymore. He used to come in and work in the morning. He'd lecture to students, and he was all over the place, and then he worked in the afternoon. But at this point, CGH Pediatrics moved over to children's.
That was
and
in 70.
First the inpatients moved, and then
1972, I think. So no, 75 or 6.
Yeah.
75 or 6.
Maybe even a little later
that
than
was
that.
the levy.
I think by 78 or 79 it was complete.
Right.
Even the big thing was all the ED visits. They
Right.
had 3 or 4 times as many ED visits
Right.
Here as across the street. So they needed a bigger place. And so then Dr. Weil died rather suddenly, and really a shock to me and to everybody, in September of '82. And then Dr. Schubert asked if I would take over. So I was the acting director. I'm not sure how long I was acting director, but until I showed that I could do it, I guess. So anyway, so I did that until when did I? 99, when Tom Welsh was the director, and then when he became chair at Syracuse, Connie started doing it, and then and then anyway, it's a long story, but.
Nick, can you tell us a little bit about why you decided to stay on as faculty and become director of the lead clinic here?
After completing my training here, it seemed like the most logical thing to do at the time. I mean, after Dr. Berger had retired, there were a couple other physicians and myself who were working like part-time in the lead clinic, and
I think Adam Spanier.
Yeah,
was like 2 years.
Yeah, Adam Spanier and Steve Wilson.
Yeah.
And they left in like kind of quick succession, and then it left me. And I was actually still finishing my fellowship over at UC, and they made me the interim director. It sounds like there's some similarity to these stories.
But you were a faculty.
No, not yet.
Oh, you weren't faculty at UC yet?
No, I was
Okay.
still a fellow.
Okay.
And basically I was moonlighting and became the moonlighting as the interim director. And then I stayed on because there was an ongoing need. And I divided my, initially divided, when I started my faculty position, I divided my time among a couple of different clinics and then some other projects. So I was working, it was during that time that we added Northern Kentucky as a location for the lead clinic, and integrated their public health nurses into the clinic. And also I was working in, we had an ADHD medication clinic, which was with Phil Lichtenstein. And and I was working in the primary care clinic. And then I had, now what happened kind of in the interim was this funding from the CDC had started, like EPA and CDC had seen the importance of trying to do outreach and prevention and to provide consultative services to the greater community around pediatric environmental health. And
So what you expanded beyond just lead to a more global picture of the environment and water and...
Right. And we've actually had, even just in the last like couple of weeks, other exposures. Lead still is I would say is still the bread and butter of the clinic, and but we have other exposures, other metals, indoor air pollutants, organic compounds, some other stuff, and when I have like medical students we teach, residents, they basically get very little exposure to any of this. Lead exposure / poisoning, so I would say the volume of kids that we have who are frankly poisoned has dropped significantly, but we still have, in the time that I've been here, we've had a few kids who were coming in bordering on encephalopathy, and requiring admission. We still admit, a few kids per year, not like what it was. I think the other thing that's kind of interesting, I think, because like in part the work that started at UC and at Children's, looking at what lower and lower lead levels do, there's a lot more awareness about the need to screen and test and follow up. And I would say like a lot of what, some of my time is taken up with working with the local health departments and the state health department and Northern Kentucky to try to improve like what's being done in primary care settings also.
Could you talk a little bit about the role of Bruce Lanfear in your career, what he did, some of the research y'all are both involved with, and how you've implied some of the changes that have happened, but tell me about Bruce, who's quite interesting.
Yeah, sure. So Bruce was really the person who kind of recruited me here. And sadly, the way our careers went, he got recruited off like right as I was arriving, basically. And his work in terms of better understanding that really no level of lead is okay, and he and others, but like really, he so vocally articulated this, and has really changed a lot how people look at this problem. So, the residents that I work with now, and even like the other primary care faculty, like there's this general realization that like, oh yeah, the lab says 5 and above, we need to do something, but no amount is okay. And so, in some ways, like Cincinnati Children's has really kind of taken the bull by the horns and said, these kids, no matter what level of exposure they had, it's still much higher than what most other kids are getting exposed to in the rest of the country. And so, we need to be more diligent about following up with them and making sure that the lead levels don't go very high. And my colleagues, in fact, have been really working very hard on that. And now, you would maybe laugh at a lead level of 3, but the kid who had a lead level of 3 at one visit, because it wasn't 0, someone checked it again and it came back like in the 50s. And so, that child was already exposed to 3 or 4 times the amount that other kids were, and now all of a sudden, like, we have a big problem. And I think what you did, Dr. Berger, instead of setting up this relationship with the health department, is like one of the unique things that we continue to do. And most other, I think, as like a hospital and as a group of people, we understand that this is outside our walls. That, yeah, we take care of the kids who come to us, but this is a much bigger problem, and it's getting better, but it requires more than just a bunch of good-natured doctors and nurses. Like, there has to be a lot of other changes.
You've inherited some people from Dr. Berger's team who've worked with you. Tell me a little about the other team members.
Yeah, so over time we've had a lot of changes. I mean, when I first started, we inherited one of the nurses who had been working with Dr. Berger. We now we still have a dedicated nurse to the clinic, and we've worked really closely with social work over the years to try to help families get resources, because I think it's, unlike a lot of problems, so there's probably no other like blood test or medical test that gets done that, the response then is you have to leave your house. And, this leaves families in really a mess. Our medical treatment is important, but I think trying to help the family overall is like very important. And, a lot, I mean, you hear like Bruce's work, like, quoted over and over again when people are saying, well, we need to do stuff to prevent this exposure. And, and the state is trying to tackle the housing end of that, which that's a big task. But I think it has to start, well, it's been started. It has to continue as, we live in an old city with lots of legacy housing, and this problem hasn't gone away.
When did Medicaid start requiring all of their babies, to have lead screening? Whatever, I think they have to have it once in the first year, once in the second year.
Yeah.
When did that become a standard of care?
That's a good question. I can't. Right now, I can't
do you
quite
remember
recall.
when that?
No, I don't have a date either, but I think that it's been for at least 20 years, probably.
Yeah,
longer.
I mean, I've been in practice since 2001, and I know, that it was required. I mean, it was required then.
And the referrals that come to you from the primary care clinics, what's the magic number where they will refer a patient?
It's kind of interesting. Like now, I would say lead has become something that's uncommon enough that people, physicians aren't 100% sure of what they should be doing, but not so uncommon that there aren't like a steady stream of people. A lot of doctors now, since the CDC or public health is a kind of response level, they call it a reference level right now, is 5 micrograms per deciliter. I get a lot of referrals for kids that are 5 and above. And, quite frankly, those kids don't require an enormous amount of medical management. Mm-hmm. However, as we've started to look at risk factors for lead, exposure, lead absorption, we're certainly uncovering a lot of issues around diet and housing and other things that, my thought is that if we can prevent that kid from becoming like a serious case, we've done something good. And interestingly enough, the work by Bruce and others show that really a lot of the damage occurs in those first few micrograms per deciliter. So anything that we can do to reduce that, I think is beneficial. But there's
been a lot of activism. I think probably exacerbated by the Flint, Michigan
Right.
issue. I think you've been involved as a consultant for them. Tell me a little bit about that.
Yeah, so that's a very, I mean, that's an interesting and kind of like horrifying problem that had happened at all, really. I, strangely enough, had known, I had met Mona Hanna-Attisha, who's the physician, everyone calls Dr. Mona, I guess, when I was a resident, because I trained with her husband in Detroit, and she was a couple years behind us, I think. And when that whole thing started to happen, since we're one of the federally designated kind of expert centers, I got some contact from her and other people in Flint. And I think what it tells you is that what I said before, like this is still a pretty common problem, but not so common that a lot of physicians know all the things that they should do. And I made a few trips to Flint over the last few years, and a lot of phone calls, and trying to help out the physicians there understand like what is how are we going to manage kids who have, for the most part, there were no children identified with like extremely high levels of lead. I think maybe one the CDC found, but but for the most part, it increased the percentage of kids who had lead levels that were above the reference level. And I think one of the problems that you run into with prevention and public health is that a lot of it is just not. It's not very sexy. It's not like exciting. It's like, okay, we need to get your water taken care of. You need and the water system in Flint was really, a lot of stuff went bad there that is incredibly unfortunate, and obviously that's working its way through the courts and a whole bunch of other places right now. But it certainly put lead back on the map.
Yes.
And I think it's allowed us to take a moment to say, hey, this is still an important problem, and it's becoming a problem in other ways. I mean, you would be surprised to find out that one of the growth areas for me is suburban children who live in fairly new housing, like built within the last 15 years, that are eating imported food and have lead levels that are running, anywhere from, 8 to, 25 from consuming like items that come from overseas. So this is a global problem. And so, I mean, Flint does like kind of like shine a light that, yeah, this is still happening in the US, but, people weren't, doctors in Mason weren't necessarily looking for lead exposure, and now they are, because they found a couple of cases from families who had, it all came from food. And unfortunately, like this problem just hasn't gone away. And I think, the Flint issue has kind of gotten people, has shaken people out of a little bit of their torpor, I think, about it. And hopefully it will shake us to do more sustainable and kind of logical action to prevent the problem.
So there are other, obviously, environmental problems. I know that some of the young researchers in general pediatrics have been looking at neighborhoods in Cincinnati which have a number of issues, the air.
Right.
And are you a consultant for them in terms of some of that research that's going on?
Yeah, so interesting you should ask, because a lot of part of my time is actually being physician on various studies. And, there are some related to air pollution, some related to other toxicants in the environment that, have similar effects as lead, but we're not screening for them. Like the similar problem you had, it took like 3 vacutainers of blood for a lead level. Well, to measure, brominated flame retardants, there's only a handful of labs that can do it at all. But this evidence showing it has similar effects at, the levels that people are, similar to lead, at levels that are comparable to this like environmental levels that we see now. And my projects as a fellow / graduate student was looking at air pollution and its effect on behavior. And in fact, like we use lead as kind of the prototype, you know, and it was Dr. Dietrich, Kim Dietrich, who basically came up with the idea, like, well, gosh, you know, if this can get into the brain, maybe it will do things similar to what some of these other toxicants are. And of course, he's been involved with lead research in children for, you know, decades, and a very strong advocate.
And you worked with Kim.
Oh, yes.
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 Who's-
Came in roughly 1980.
Yeah.
And so when we were applying for the program project, the long-term study cohort, so we needed him.
I mean, all of this, from my perspective as a generalist, is there are children that need not be at risk for disabilities from environmental issues. They have enough problems as it is with clothing and food and so forth. And I think that's probably, I'm putting words in your mouth, but it's probably one of the reasons you got interested in lead is those kids were damaged in some way.
Correct.
Did y'all have follow-up of those kids in terms of their development? And I don't know if any of the psychologists were involved as you went along.
Oh, they indeed were, more and more over
Yeah.
time, of course.
Uh-huh.
And certainly those that were having symptoms or persisting symptoms were referred. So they didn't see all of our patients, but only highly selected ones. And so,
But they remain, particularly for kids that live in the inner city. As I said, that's certainly in politics of environmental health, Dr. Newman.
Yeah, that's luckily I majored in biology and political science in college, so that's come in more handy than I ever would have thought. But I think part of the issue is that we've, in a lot of ways, the environment kind of writ large has become like a place to externalize costs of all different kinds. And you know, right now, I think one of the hard things is balancing what these costs are to human health against the cost of fixing, changing how we do of whatever. And I'm encouraged by the fact that, I mean, certainly lead as a problem, like if you look over time, like this is getting better. Like we're making progress, and you know, our standards are very high. And so it doesn't look like we've gotten anywhere, but like we really have gotten a long way. And I think for some of these other environmental toxicants, there's a lot more public awareness of it. But I think what also needs to happen is like we need to impart some knowledge about how these things actually affect people's health and what can we do about it. And other than, you know, I think a lot of people, they see this as such a huge problem that they don't even want to tackle it. But in fact, like lead was a huge, it still is a big problem, but like we've tackled it and it's getting better. Like it's not going to be, I mean, it wasn't solved in 40 years, you know, but it's better than it was 40 years ago. And you know, these other things, as we become aware of them and we start doing things, it will get better. And I guess I'm an optimist.
Good.
But you know, I think politics is complicated. Even Einstein said that it was more complicated than physics, because you're dealing with human beings. But I think if one of the organizing, I mean, it was pediatricians who said children are being harmed by lead, and a few good people got together and said we need to do something about this. And I think that's how a lot of things change.
Yes.
And unfortunately, children are probably the most vulnerable to all these different things. And we as pediatricians need to shine a light on that. And we can't make all this stuff. We can't make politics go the way we want, but we can educate and advocate, and because that's what we do best.
So as we wind down Dr. Newman's perspective in the future, tell me a little bit about when you look back at your career, what do you think was the most important things that you did, the most enjoyable things? And I think you've talked a little bit, we both talked a little bit about the balance of your life, how you balanced home and career since you had 75 different jobs.
Right. It's a very difficult job of balancing. Really, it is. And I think following patients is very rewarding. So I had the opportunity to do that, especially in the baby smoke fund. So I would follow them, maybe not as long as someone in private practice, but I would have a relationship with the family, the mom and the dad, and sometimes the dad would bring the kid in, etc. And so I had that down at Findlay Street, out in Addiston, and in the outpatient here as well. So especially after I retired from academic work, and I just worked in the PPC, and that was really fun. And then the other part of it is teaching students and residents. Right. So I found that extremely stimulating and fun and rewarding, and I wouldn't change anything.
Good. Well, I thank both of you. I think we all learned something today, and congratulations on your career and good luck in the future. Thank you very much.
Thank you.
Thank you, Mayor.